That was one of the driving forces for me going from paramedic to PA. It was, I always just wanted to know more. And, you know, when I would deliver a patient to the ER, I'd always want to hang out. I wanted to see what they were doing. I wanted to know why. I wanted to know what happened later, an hour a day, a week later, what happens, why are they doing this? And I mean, to this day, I have even more questions than I did then, a lot more. But that was definitely one of the driving forces for that. And knowing those things. Some of the lab values obviously doesn't really matter, but you know, you do need to know some, and it does affect your care because what are you looking for? You don't have lab values, you don't have CAT scans, you have nothing but your assessment skills in the field, and you have to think 10 steps ahead all the time as to what you're doing. And those things do matter.
At minimum, like a critical value. We have people that come in all the time and my labs are abnormal. Which one? And then people will say my sodium is whatever that is. I'm like, that means nothing to me. It took a long time for me to be like, oh, I want to get an EKG on you, you know, and it's not just this is going on. And so, because we're not roughly taught, like, based on someone's EKG, if they're lacking or an excessive amount, but if someone comes in and are like, I can tell, you know, my sodium's low or whatever is going on, it helps a lot more. So at minimum to know like what the critical ones are. Or if someone comes in like my creatine's high, I forever had no idea what that meant. And I was like, I don't know what a high creatinine
and paramedics should definitively know those.
Oh, absolutely. I think to be a helpful EMT, it's good to know that to help the paramedic. But if you're doing cardiac and ALS, you
100%
absolutely need to be able to look at someone like, hey, that's I don't like what I'm looking at just based on that. Or if a patient says I have a history of this, you can go, oh, so this is probably what's going on.
And we're starting to see, so there's the EMS Agenda 2050, and then there's going to be where we'll see the EMS Education 2050. And I anticipate that we will be seeing much more expectation of that additional knowledge. So.
Well, how many, nursing homes do we run to that have some lab work that's recent, and that's what they're concerned about? And if you don't know what you're looking at, or if they don't have the normal values listed on there, you know,
you're just looking at a bold number.
Exactly, and you don't know, like, where on the spectrum, is this a little bit abnormal? Is this a lot abnormal? You know, and those things do make a difference.
You don't know what to
Which
anticipate.
Ones do you have playroom with? You know?
You don't know what to anticipate
Potassium,
for your
not much,
patient. For
I've had very few that I can think of paramedics over the years that literally come to mind that have said, hey, the patient called because they said they were called about an outpatient lab where their potassium was in the 2s, and I noticed this EKG has like U waves, or their heart rate's 46. Like, they jumped right to it. I'm like, how? That's impressive. I don't know the last time I talked to a paramedic who would have put those two together.
Which is
important.
And actually
life-saving.
blows my mind because actually my program, every paramedic should have done that.
Yeah.
Well, when you and I started,
Now this is,
it was a long time ago. So the paramedics.
It was a couple minutes ago.
It was just a few.
a hot
minute.
It was a hot minute.
No, it was a hot minute. But the paramedics that were teaching us, that was like first day learning.
Right.
There was
that
kind of thing.
Absolutely.
But, I don't know. I don't see that a lot.
You don't, do you? Yeah,
no.
I don't. Yeah.
That's very disappointing to me.
It hurts my soul every day. It hurts my soul.
It hurts my soul because I know it's taught.
I don't know. I feel like I do see them, like, because a lot of times the paramedics will come ask our opinion on the EKG, and honestly, we give them more superficial answers than they're looking for. I see a lot of docs give them very superficial answers because I know what they're asking.
Those paramedic rooms?
Like,
we would sit there and we would debate a single
they're looking at the minutia, and I see a physician giving a very superficial answer because we don't spend enough time looking at all the minutia.
100, and because my paramedics are being told that you do not need to know this information, so why are you looking at it?
Yeah.
Interesting. I would never step into that. That's not my job.
Sure.
It's not my realm of education and teaching at this point. Why would I ever make that comment?
Yeah.
And it's so untrue because I think when you are out in the field and you don't have access to lab work, you have few diagnostics, but a 12 lead is a huge one. If you can pick up on all the subtleties, it will tell you so much more than are they having an MI or not. It can tell you so much more stuff. And when we're looking at them in the ER, that's a lot of times all we care about, because we're going to get all these other diagnostics. But they need to be able to read them better than we can because that's one of the few data points they can get in the field.
Yeah, it used to be long ago, that, especially on the East Coast, you remember Tyson? He was talking good bumps and bad bumps.
Yes.
Absolutely not. Right, and that's and that is not the level of 12-lead interpretation that I think we expect. Now, mind you, that level of 12-lead interpretation is well above the national expectation. But again, in the field, you do not have, as a general rule, some of our systems do have some lab values and some things that they can assess, but as a general rule, our clinicians in the field do not have these resources available. So they have to rely on their assessment techniques, their assessment tools, and they have to do good assessments. Otherwise, they're doing a disservice to their patients.
And it hurts my heart. It offends me a little bit, honestly, to hear that, a lot of this applies to education for every level, so I'm going to make this comment from the physician standpoint because it applies to medics and EMTs and everybody else. That the fact that anybody doesn't make the extra 25 seconds. I work in a big level 1 shop. I don't have any extra time, but you know what gets extra time? When a paramedic stops and asks me one of those minutia questions about an EKG, I'll take 25, 30 seconds to go over why it is or it isn't that and to teach a point about it. And the reason being is it's beneficial to me. After all these years, how many times have I refreshed myself, and I'll answer this for myself in a minute, on some of that minutia? My answer is freaking regularly, because I will not miss those opportunities to teach somebody else what they're interested in, because knowledge is power. If I've got something that someone else can learn from, I'm going to give it to them. And the benefit to me is I just reminded myself through teaching the thing you're supposed to be an expert in. I may not be a cardiologist, but I know I'm expected to be the second best cardiologist in the hospital when you're an emergency medicine doc, just like everything else. So how do you keep all the skills of every specialty, which is our job, up to par? You practice them, or you read about them, or you teach them. And those are quick teaching moments. Every single one of us has time to do that. Now, if you don't know the answer and don't remember it anymore, then you have to decide, is that important or is that not? And you should just be honest about it. But it's probably important because we're called to be expert at everything all the time. So these are one simple way that you can continue to stay up to date is by sharing that info that you have to drudge up. So why not? And again, I don't have any extra time in my 10-hour shift. I have time to do that.
How much of that do you think comes from your pre-hospital career, though?
So that's a good question. It's probably biased by two things. Number one, starting as a medic. I'll give you that. The flip side to that coin is that I wasted another 4 or 5 years after leaving that field before I thought, golly, I got to go to college to do anything myself. This sucks. So there's a big gap there. I don't know about that. That's a long story, but
it got you here.
Here I am eventually, right? And then the other bias to that is probably I'm an associate professor at the university because I love to teach. So some people despise teaching. They won't do that. So be it. They want to do their own thing and go home. I get that. But at the same time, again, for your own benefit, you're called to be expert in just about everything. There's no way to do that well other than continue to learn. Finding time outside of work to sit down and stay fresh on articles, to attend conferences, that's hard. So be efficient on your shifts, get your butt home, spend time with your hobbies and your family to not burn out. That's the goal. So what can I do to continue to boost myself? I don't know, a podcast on a drive, taking 30 seconds with a paramedic to talk about a U-wave. Who cares? Just do it. It's easy, and it's beneficial to self.
You're in the wrong field if you're not willing to continue learning and teach the new people.
I think both. Yeah, this field in particular, I think both of those things are, you can't excuse either one being lacking.
Even if you don't have students regularly, I mean, you need to be teaching patients what their workup means too. I mean, we're always teaching, and we should always be learning.
Yeah, lifelong learning is absolutely an obligation.
Yeah, this field it is.
Plus, it keeps you young.
I think it does. Yeah, if it's not for the mental, intellectual stimulation, I mean, for crying out loud, speaking of intake, right? From a doc's perspective, if I never work another intake shift in my life, I will retire a percentage happier. So that said, it's important, And
especially with all the new things people are coming in with, and like I did that. I remember one person came in and said they took a new thing for the working out or the gym. I was like, I have no idea what that is. I was like, is it a stimulant? Is it to help you?
Right.
Yeah. I was like, did you do it on purpose? Do you eat it?
Right.
I don't know.
Right.
Yeah. And
How well did it work for you?
Yeah.
I want to try some.
Right?
Try this.
How long have you been on?
this guy was
Keep in mind that we're speaking here and hearing it before.
This guy was sweating. I mean, when I say sweating buckets, I mean,
Yeah,
I could have put like Emesis bags under his and he would have filled them.
Right.
Oh my
I was like,
gosh.
what are you on? He goes, I just took something before I went to the gym.
Yeah.
I was like, what was it? He's like, a new pre-workout. I'm like, what?
Yeah.
What was it?
It
So
sounds
My
amazing.
buddy made it in a bathtub.
yeah, just
Got it.
everything's just always changing. If you are like, all right, I did my learning, then you
Right.
are going to you will fall behind.
You will. In
Yeah.
the real world. Yeah, I remember the first time I heard the term Molly years ago. I was like, all right, it's time
yes.
to figure this out, right? So you
Right.
stop a patient and you go, can you explain that to me? And they just look at you and laugh. Like, no, I'm dead serious. You got to tell me what this is. That happens to me probably once a year now. They come up with some new name of some street drug. You better ask. You have to know
they
these
usually
things.
tell you.
And they'll straight out tell you.
But yeah,
no
yeah.
doubt.
I someone I
As long as
can't
there's not a cop in the
remember.
room.
Someone said something to me that was like glass or ice, and I was like, I
Right.
have no idea what
Right.
that is. I was
You
like, is
gotta
it up or down? Up or down?
Right.
What direction
Right.
did
And
you
that's
go
all I
in?
need to know, but you
Yeah,
got to tell me. Right?
yeah. And so or like teenagers,
that's
like
what we
new
lose in
things
the
that teenagers
ER
are doing. They
Yes.
come in, they're like,
Oh
I was
my
doing that
gosh.
new trend. I'm like,
What new
We
trend?
lose our street
Tripods.
cred in the ER.
Yeah.
You know?
And that's fine. I'm willing to say I'm old and I don't know what TikTok is. Now tell me what I need to know.
I know, just
right, because there's going to be more of you right behind you.
The only thing you need to know about TikTok is Hawk Tua.
Oh, God.
no.
Unless that's a New Zealand thing.
You know what? Just pretend
Yeah.
you never heard it.
Yeah, if you're not,
already lost it.
if you already didn't recognize it, then I'm not
Perfect.
gonna.
I'm
I don't
sorry
have
that I
brain
know.
cells for anything to do there.
Yes.
Yeah.
Truth.
I feel bad for that girl.
Awful.
Because
Awful.
just anyway.
How long do you guys think it takes to develop confidence when you're new in EMS?
You
I
said
said-
confidence, not competence,
And do
right?
you
Yes.
confidence?
Yes.
Correct.
Never.
And
I feel
should
like
you be
2
developing
years
it in
was my
school?
well,
No. You have so much to learn.
you've got the Dunning-Kruger effect. So that's step number 1.
What's that? What is that?
So the Dunning-Kruger effect is when you have this. I wish I could draw for you, but you don't want me to draw for you anyway. So that's
I do have a whiteboard. But
no. Look it up. Everyone needs to look up your Dunning-Kruger effect.
Okay.
So that's step number 1. So the concept is that you feel really, really confident. It actually goes back to what Tracy said about PA school, where she's like, I went to PA school and I wanted to learn all of these things, and then I realized that I didn't know more of all of these other things, right? Which is, I think, what we've all experienced, which is not saying that Tracy had Dunning-Kruger, but the idea that like the more we learn, the more we realize we don't know.
It's true. The more you learn, the more questions you have.
That's correct, right? Which is what we
how
should
it
be
ought to be,
experienced,
right.
right?
Always.
That is what we should be experiencing. So the idea that initially
Exponentially.
you start to feel incredibly confident, right? So when you're in
never had
EMT school, you did.
That's personality.
I,
She is
I had
telling
it.
the truth.
I had it when I was an
Tracy.
EMT.
Yeah.
Yes, right. And Tracy is actually probably one of the very few people that didn't experience that. And knowing Tracy, as long as and Tracy is one of my dearest friends, and it doesn't surprise me at all that Tracy never experienced that.
Right.
So, but in EMT, most of us going through EMT did experience this like elation of now I know everything and I can save everyone on the planet, right? So you're really high on this Dunning-Kruger, and then you get out and then you're like, I know nothing. And so then you get real low.
Okay.
And so you definitely need to look it up. One of my faculty members, Ben, does an exceptional job of explaining Dunning-Kruger.
I can only.
Yes, as you can imagine.
Ben
Exceptional
also has
job.
chainmail. Let's just say that.
Chainmail. Oh
Chainmail.
yeah.
Oh yeah, with his like
He's way into
actually,
medieval
just
sword
for
fighting.
the record,
I watched him clean it one day. It was impressive.
Ben now has a full suit of armor, custom made to him. It is beautiful.
This is awesome.
Yes,
I don't know
phenomenal.
why you need it, but that is awesome.
Yes,
Awesome.
yes. Swords, all of these things. Ben is an exceptional human being. So I think that confidence, going back to confidence, now that I'm off Dunning-Kruger, it's going to depend on the individual, and I hope that it's not the false confidence, right? Because the people with that false confidence up at that top of that Dunning-Kruger are incredibly
I just hope
dangerous.
they have some fear with their confidence.
Yes,
Yeah.
that's it, right? Because
I feel like as a paramedic, it took me about 2 years to be comfortable in my skill set, and then as a PA, 3.5 to 4 to be comfortable in my skill set.
Okay.
But again, for me, it's always, oh my gosh, the more I learn, the more I know that I don't know.
So you probably never got to that part of the curve where you're a very dangerous human being.
Right.
Well, I wouldn't say that, but I mean, no, I don't.
That's personality dependent for sure. You and I are very different, right? Very different that way.
Yeah.
Which most people figure out pretty quick. There's no doubt that I will hit that Dunning-Kruger ceiling and then bounce off it a few times. I know it all. I just got humbled 3 times in a row right there.
Yeah.
I think I would say my curve was, as an EMT, it was way up here. As a paramedic, it was a little bit lower, and then as a paramedic, maybe even, or as a PA, even a little lower.
Sure.
As I realized, where that does affect me every single time. Because when I was a brand new EMT, 6 months out of school, I knew everything.
Right.
I was providing just terrible patient care and thought it was great because I was like, I know there's nothing wrong with this patient, and God knows what was actually wrong with him. But I had a great paramedic. I think I talked about this last time, but Matt, he taught me so many good lessons on the ambulance, but he caught that real early in my career and really beat it out of me. He was like, hey man, your report was really terrible because it was very clear you wrote off this patient. And at first I'm like, oh no, they think my jokes are hilarious. Like I had him rolling. I was so funny. He's like, bro, it wasn't that funny, man. Give a serious handoff report. And after, some reflection on that, and he did that quite a few times with different things, and it really changed kind of my trajectory and probably got me off that curve a lot quicker than I would have otherwise.
Yep. And it makes a big difference, right? Your partner does make a huge difference.
Yes.
Because if you had a partner that encouraged that behavior, it would have, can you imagine where your trajectory would have been?
And I did have those partners, some of those partners would, and it would make it worse and worse. And then I would have somebody that'd be willing to work with me to actually improve that. But you do have the partners that encourage that behavior.
That's exactly right.
There's both a mound of anecdotal evidence and some literature to support in the field of emergency medicine at the physician level. Confidence and competence. So let me say this first, I guess. Confidence and competence as an ER practitioner are very similar. Once you are more competent, you generally ought to be more confident. So I'll put those two together. There's a pretty good amount of literature to say that 10,000 patient interactions in the ER as a providing physician, as a solo and attending physician, will get you as close to appropriate competence as you ought to be eventually in your career, which means a confident provider. And on average, this is mostly anecdotal, I have heard, seen, and experienced, I'll agree, about 3 years of attending physician position at a sizable shop with a good exposure to patients. How that corresponds to 10,000, I don't know, but about 3 years leads to a reasonable and not necessarily hazardous amount of confidence. And for myself, I would say that was pretty stinking true. I am not the personality to come out of residency and feel nervous, and yet I was terrified. And I will say that it was like starting residency all over again. And I will say that waned its way out right around the 3-year mark. I thought I'm no longer nervous to walk into a shift somewhere during that period. So I would probably safely assume that each position they're under, PAs, NPs, paramedics, EMTs, are going to fall somewhere within that spectrum. I would ballpark, I'm guessing. I'm not calling the physician a pinnacle position. I'm simply saying I would think that based on the realm of scope of practice and education that comes with that, it would fall within there somewhere. I would ballpark. Confidence, though, to ask that as a question is so subjective. It's not subjective. It's personality-based. Yes. It's so personality-based. Yes. You, Tracy, my wife, she was a nurse for 8 years. To get her to feel truly confident, to stand up and go, I've got this, is going to take hours, patience, things above and beyond what it takes someone with my personality to admit to or feel. So I don't know. I feel like the question leans more on competence than confidence. So I don't know.
I think I was at a year. I was on the ambulance after I had done my FI. And then I couldn't believe they let me loose by myself. I was like, this is the stupidest fucking thing I've ever seen. And then I'm out on the streets, and same thing. Like every time I would go, I was nervous to go to work, and then we would go to a call, and I was like, holy shit, do I know what I'm going to do? And then I'm thinking through, this is the dispatch information, this is how I'm going to treat this patient. But we were in a busy system. I worked weekend nights in a busy system. And so I would say it took me about a year to feel like I'm not scared out of my mind every time I got dispatched to a call. And so after that, I was okay. And now it did take me, because after that point, that's when they start asking you to precept students. And I would not take students. Because it wasn't fair. Shortly, about 3 years in, I did start taking students, and then there was 3 of us that would trade students around, and then we had a whole curriculum that we put students through, because I've always enjoyed teaching students, and so obviously we're going to do that. But because it wouldn't have been fair to a student to put them with a brand new medic, and a 1-year medic is still a brand new medic.
Mm-hmm. I think paramedic, I want to say I was probably a year and a half. PA, I was probably 2 full years before I was. And even now, I feel like I'm just well aware of where all my deficiencies are, too.
Absolutely.
And I just know where I need help. There's some things that I feel like are pretty easy for me, and some things that are still very difficult, and I just know where I need the help. I know the patient complaints or presentations that I'm uncomfortable with seeing on my own, and that I need to staff with a physician. And I think it took me 2 years to know exactly where that point was. I know exactly all the patients I'm very comfortable seeing on my own and discharging, and I know all the ones that I'm not. And I think it took me a good couple of years to get to that point.
This will sound a little counterintuitive, but a couple things. Number one, I think it's important to actually develop confidence in this field.
Yes.
I think you'll never do the best by any given patient until you are reasonably confident. That doesn't mean cocky. There's a fine line there.
Absolutely.
There is a fine line there. I know. I walk that line. I get that. And you just have to know it. You just have to know that, right? But it is important to develop some confidence to act. It's a field where you're going to have to do something sometimes.
Right.
Yes.
And it's also a field where you're going to have to realize now's not the time to do anything.
Exactly.
That all takes confidence. Yes. So I think
that's
to get there,
sometimes the hardest decision.
Yes, it is.
Don't just do something, stand there sometimes.
Yes.
That's hard until you're confident that you know something.
Absolutely.
Now, to get confident, this is the part that might seem counterintuitive, but I think I'm right on this. It's important to know. I'm going to say this slow because it's going to trip on my words. It's important to know that you will never know what you don't. You cannot see what you don't know till you experience it. And there's always going to be something you haven't probably.
Correct.
I have no doubt in this field. Things are always out to get you and surprise you. So you can't know what you don't know. But as long as you're willing to always, forever admit that, I think it will build your confidence. And you have to get to the point where you're confident enough to do well.
Yeah.
Or you might not even make it in the field. After years of education and time and sometimes financial burden, you might not if you just can't be confident enough to get over that fear of going to work eventually.
Yep.
I feel like you have to have a sense of confidence enough so patients who have no idea what's going on and are scared are like, all right, I'm in good hands. But also, so if you are wavering constantly, if you have way too many directions to go in, it's really hard to tunnel vision. So confident enough to stand your ground. I remember, I hope this doesn't make you mad. One of the first shifts I worked with you, this sounds kind of weird. You like to talk out loud with your differentials.
Nobody can figure
and
that
it was
out.
a patient that was
listening to that, by the way. I love it. I learned so much from that.
I want to say they were hypertensive, but there was something else going on, and I can't remember what it was. And you were like, all right, if I give them this, I tank their blood pressure. But if I give them this, they have a risk of stroking out. And I'm like, that is the worst pressure I have ever. And you were going back and forth for probably 10 to 15 minutes.
Hang out and listen to this.
He's fantastic to listen to because you learn so much.
I
would keep talking.
That's all I was doing was standing and watching you. I was like, it's like he has a button in front of him that's like, okay, nuke the world or don't nuke the world. And you were like, all right. And I was like, is anyone listening to him? Like, it sounds like he's making a life or death situation right now. And you're like, all right. And I'm sure they walked out of there that day. But I was like,
and he does it in about a nanosecond.
It was, and no one else was percepting it. But it was, you had yourself in check enough where you were like, outside feedback would be great, but you were like, I know for a fact these are the two options that I have to have. But that was like, you were making me sweat. And I was like, oh my gosh, what kind of decisions are we going to make right now? I can't figure it out.
It annoys the shit out of a lot of people, but I think a lot of people eventually might learn something from it.
I mean, it made me, that was one of the things where I came out and I had not like a God complex sense of confidence, but definitely like I am so much more knowledgeable than I was. And then I remember hearing that conversation and going, I know jack. Like I would have just been like, give this person this is what they need. And I like knowing the differentials like that. And so hearing that there's so many different things going on at play. Or I remember asking Aaron one time, I was like, why did you put a D-dimer on this person? He's like, oh, well, X, Y, and Z. And I was like, that makes no sense. He goes, you're going to feel really bad when they have a PE. I was like, okay.
Did they have a PE?
She ended up having to get a CAT scan for something, but enough to where I was like, all right.
For a falsely elevated dimer is what she got the CAT scan for. That's okay.
Yeah.
So that's actually...
We're going to say I caught a PE.
You absolutely did. She wrote you a thank you card a month later.
There you have it.
So that's actually one of the really important things that we see with EMTs coming into paramedic school, especially EMTs with a lot of experience, because the EMTs that come into paramedic school, right, you're exposed to all of these things. You've got all of these high-level thinking, about all of these topics, except the only thing that's lacking is the background. And not saying that you're lacking background, right? Because you have all of this information, but the pathophysiology of it.
The why.
Yes.
Yeah.
And so what we see, it kind of goes back to our curve of we have these EMTs that walk in incredibly confident to paramedic, like, I know I'm going to do X, Y, and Z, but they don't have the why.
Yes.
And
that's what trips me up.
I'm going to give you 2 examples of this in a minute.
Yeah, and so that's, in fact, it is a barrier for them to be successful in paramedic school because they don't think they need to know the why.
Right.
Just know, like, this number means this, and this number means this.
So I have 2 quick examples of exactly that'll sum up everything we just said. And I'm not picking on I was a paramedic.
Yeah.
That's how I got here. I fell in love with medicine that way in the field. I just couldn't know enough, so I had to figure out where to go next, to know something else. It bothered me to talk to a doc who had a scope of practice yay big when mine was this big. It just bothered me. So that's all. It's a great career, and I'd still be doing it if I'd have not got accepted to med school or whatever. I'd be right there for sure. I don't care what it pays, how stressful people are. I'd have done it. Otherwise, anything else in the world I would have been bored with. It's kind of like why I'm not in any other specialty. But 2 quick examples of paramedics examples of why you want to eventually learn the details, the pathophysiology, the why I should or shouldn't do, and the confidence you need to do nothing. I have had in the last couple of years a medic come into my emergency department with a young mid-20s female who sat on a urinary tract infection for over a week and sure enough had a raging case of pyelonephritis, floridly septic. And I remember standing at the door listening to this paramedic, who I have no opinion about to this day. I get where it came from. It just shouldn't have happened this way because someone needed to have the confidence to do nothing. They were coming in with this patient whose pressure was a little soft. Granted, this is a small female, so safe enough, 95, 100 systolic. But the heart rate, she's got a fever of 103. She's a 26-year-old, if I recall, marathon runner, healthy female. Heart rate is 160 steady. Okay. My heart rate goes 160 when I walk into the gym. I mean, I can do it at 42. She can do it at 26, no doubt, right? So she's going 160 beats a minute because she's febrile and septic and has a story to say, I'm febrile and I'm septic, right? So why'd she get adenosine twice en route? Right. So the paramedic says to me as he's giving a report, he's almost done. I'm totally listening to him, and I don't know if he thought I was because I'm looking at the patient now, getting her on the monitor, asking for a second IV because she's clearly sick. And I hear him say, so the 2 rounds of adenosine didn't change anything, and I stopped dead where I was. And I said, where's your strip?
That's exactly what I was going to ask you.
And he said, he got it right here. I said, we'll talk in a minute. Yeah. Because I already know what happened. So I finished getting the nursing orders situated. We're all talking about, okay, we'll get a second IV. We'll hang this type of fluids. I'll be right back. Thanks. Patient's clearly stable, just sick. She's 26. She's not going to die. So I go walking out the door, and I said, give me your thought process on the adenosine. And he's nervous now. You could see it on his face. Not because of me, because he just knew. Should I have done that? And you could see it on his face. So I wasn't trying to hammer on him. I knew he already realized something's awry here. And I said, okay, just show me your strip. So he hands out the strip to me. And I said, tell me what you see. And he says, she's fast. And I said, she's real fast. And he goes, she's real fast. And I said, I know. I said, one question before we get going on this party. How long's your transport time in this big stinking city? He said, 5 minutes. I said, right, okay. Blood pressure was stable, right? Yep. I said, okay. So tell me what you see on the strip. And she's fast is not the answer. He goes, I see. And he couldn't answer me. And I said, all right, what is this right here? And he goes, he could. I'm just saying he's nervous. And I said, what is this? And he goes, it's a P wave. And I said, so you're telling me this is sinus tach, right? And he goes, yeah. I said, so what's the adenosine for? And he goes, it was just so fast.
It's 160. I mean, that's not so fast.
And I said, a 26-year-old healthy female, and I'm looking at this tall, slim paramedic. I said, guaranteed you can hit 160 in the gym, right? He's like, yeah. I said, so why do you think she's going in sinus tach at 160? He goes, I think she's septic. I said, so why did you give adenosine? And if the answer is she's so fast, this conversation's over. And you just turned and walked away.
What?
I had the look on my face like this conversation should be over. So that was the end of that. That's a moment where you need to be confident enough to go, this doesn't make sense.
Right.
Maybe I should do nothing. And I'm 4.5 minutes from a hospital.
And that's exactly why you need to know the why and not
why.
the numbers.
Right?
Yes.
Yeah.
The alternative to that, about a week later, oddly enough, I had a very seasoned paramedic come in and say, and you guys have all seen this, I guarantee it. I have a patient who's now in the field, was 105, 110 systolic. This is an older person with a good story for an infection. If I recall, I think it was a pneumonia. He's clearly sick. He's on his way to being septic, and they know it. Transport times are short. We're in the city, right? Unfortunately, this guy has a long history of AFib, so of course he's in RVR when he comes in. You'd be tachycardic. I'd be tachycardic. He's tachycardic. But it's AFib because he's an old guy with AFib. So he got a nice big slug of diltiazem because he's AFib with RVR, right? Except he's septic. So now I have a patient who's 60 over 30, and I'm having a hard time fixing it. So I said to the paramedic, do you realize his story is infectious? He goes, so yeah, I think he's septic. I said, I agree. So why the 20 milligrams of diltiazem? He goes, well, he's at AFib with RVR. I said, I got to tell y'all, I hear this every day. AFib RVR equals adenosine. AFib RVR equals adenosine. AFib RVR is his version of sinus tach when he's sick. Now I have a hypotensive patient that I'm having trouble correcting.
Yeah.
And he was like, his eyes were this big. I said, I'm not trying to yell at you, but this is how you assassinate a patient.
Right.
Sometimes the right answer is to be confident in doing nothing. And not every algorithmic answer is the right answer. This is why you need to know the why. AFib with RVR doesn't equal calcium channel blockers.
Absolutely not.
It means here's one of your treatment options.
Yeah.
The others are fluids. The others are time. The others are come to the ER and ask, do you think we should treat this? He's stable.
What's the underlying problem?
There's the problem. If you don't educate yourself on that, you'll never think his RVR in AFib is my sinus tach. Let's just sit tight.
Or just,
Well,
oh, sorry, Aaron.
Let me just jump in with a paramedic that did nothing correctly the other day. This was just maybe even a month ago. A paramedic, Amanda, brought in an AFib patient, probably newly in AFib, history of AFib, but not normally in AFib, anticoagulated, normal rate, but still in atrial fibrillation, but pretty borderline blood pressure, 100 systolic, maybe some pressures in the 90s. This guy's normally hypertensive, and she's got the pads on him. And she's like, I was debating the whole time, do I need to cardiovert this guy? His pressure's getting softer and softer. She's watching it. He's not fast, don't need to control the rate. And the whole time she was prepared to cardiovert this guy. And, she wrestled with that decision the whole way in, decided not to do it. And sure enough, we get the patient. His blood pressure's soft. We talk with cardiology because we think, we probably do need to cardiovert this guy. And cardiology's like, do not cardiovert that patient.
Okay.
Leave him in AFib. Send him home. His pressures came up a little bit, but at the end of the day, she did the right thing by doing absolutely nothing, but being prepared to do the intervention the whole time. To the point where we're still transferring the patient over. She's leaving the pads on until we put our pads on, and and it turned out that was absolutely the right decision, backed by cardiology.
And it's uncomfortable.
Yeah,
right.
Absolutely.
It's uncomfortable to do nothing, especially when we've got all sorts of stuff that we can do.
Yeah.
But you have to, like you just said, we have to be prepared we have to anticipate that change, but we all know that the best treatment can very often be that we're going to set ourselves up for that success, so we're not behind if we've got that real precipitous change. And then we're going to take them to the hospital so that we've got more resources, experts, and access to specialists.
Mm-hmm. And I made that mistake when I was a paramedic, being too aggressive.
Sure.
Because I think you, especially with these dysrhythmias, I think you feel like you have to sometimes,
Sure.
and your idea of unstable sometimes incorrect. When I was a paramedic, I thought unstable is like, well, they're having chest pain or they're feeling short of breath, but their blood pressure is normal. It's like in the ER, or more experience, you're like, well, is their blood pressure bad? Because if it's not, we've got some time to work on this and consult the specialist and sit on them for a while and see if things improve.
Cardiology in general, I would say that's probably the peak of your stressful patient. So I get that. I do.
Mm-hmm.
That's probably the peak of stress.
What you were saying is like this guy's AFib RVR is my sinus tac. My not favorite, but like one of my first questions is, what are you usually at? And I remember this guy came in and he was. And I am not exaggerating. His heart rate was 30, and I was like, huh. And he was like, my heart rate's low. I'm like, how low is low for you? And he goes, 30s. And everything, I can't tell you how many times in people's charts, I'm like, this is their baseline. For the love of God, do not make the no cardiac alert. This is their baseline. And he's walking, talking, standing. And I was like, that's not a lot of wiggle room for you. But, I guess so we don't get distracted by that. This is your normal. Or knowing someone that is a smaller person coming in, like, you can sustain that high heart rate. I've had a kid who was, or had low heart rate. And I'm like, you look like you're a biker, you're a fit. I will accept your 40s and not jumping and running with it right away. So that the why and then the history and like where patients operate at has helped me from jumping the gun right away and being like, you are a scary looking person. Like, no, you're a small person. That's why your blood pressure is concerning. You would count as a full trauma, but you are a tiny person. And so that's helped a lot. But just knowing where someone like typically hovers so you don't get distracted or swayed by that took me a minute, and I'm still learning how to get to that.
But I think that question, it's that clinical picture, right?
Oh yeah.
It's not just, we teach you numbers, right? Black and white numbers, which is actually garbage. We have to give you a baseline to start, but then you have to learn, you have to trust the clinical picture, you have to trust your gestalt, you have to trust all of that.